We're going to talk about types of dialysis today, describe the nursing management, and we're going to also explain the principles of CRRT, along with hemodialysis, peritoneal dialysis, and we're going to look at the advantages and disadvantages of the different types. So what is dialysis? Dialysis is the movement of fluid and molecules across a semi-permeable membrane from one compartment to another. It's as simple as that. Substances move from the blood through a semi-permeable membrane and into the dialysis solution or dialysate. It's used to correct fluid and electrolyte imbalances, remove waste products and kidney failure, and it can be used to treat drug overdoses. There's two methods. We talked about peritoneal generally and hemodialysis generally. There's also CRRT, that's not as commonly used, but for your more critical care patient, we'll be talking about that. You all good with this slide, or do you need it a minute? Sure. And I would focus on the purpose of dialysis. You guys okay? Should I move to the next one? Yeah? Okay. All right. So we talked about fluids and particles moving across a semi-permeable membrane from one compartment to another. So this can replace renal function in a chronic and in acute renal failure. Okay? There's just a little picture. So,
can you go back for a second?
oh, sorry, yeah. So solutes in water move across a semi-permeable membrane from the blood to the dialysate and from the dialysate to the blood in accordance with the concentration gradients. Diffusion and osmosis and ultrafiltration are used in dialysis. We're going to talk about those. No worries. You're good? Okay, thank you. Yeah, just tell me if you feel like you need. So there's a criteria for dialysis. When we begin it, different nephrologists have different criteria, but in general, we initiated when our GFR is less than 15 mLs per minute per 1.73 meters squared. Okay, so this, and like I said, this can vary widely, but just know that number. But generally they try to be more conservative. They may give a fluid challenge first. They may look at the medications the patient's on and try to do things that will hopefully reverse it before they get to the point where they need dialysis. But usually the cutoff mark is the 15, okay? And there's other complications also. We're going to talk about those too. But in general, the general principles of dialysis have to do with diffusion, osmosis, and ultrafiltration. But different diagnoses are indicators of the need for dialysis, such as people that have clinical presentations, if they manifest certain signs or symptoms like encephalopathy, uncontrolled hyperkalemia, pericarditis, and like extreme volume overload or hypertension can indicate the need for dialysis. Some people are waiting transplants, they'll do dialysis while they're waiting for their transplant in hopes to get a transplant. And many people die waiting, unfortunately. But we're going to talk about transplants a little later. But most of these people, unfortunately, there's not enough organs for the people that are waiting for a transplant. So general principles of dialysis, we're going to talk about these, and I would focus on these definitions, okay? So principles, like I said, the principle is the solutes in the water move across the semipermeable membrane from the blood to the dialysate, from the dialysate to the blood, with the concentration gradients. So diffusion, by definition, is the movement of solutes from an area of greater concentration to an area of lesser concentration. So in kidney failure, urea, creatinine, uric acid, electrolytes move from the blood to the dialysate with the effect of lowering the concentration in the blood. Okay? Red blood cells, white blood cells, and plasma are too big to diffuse, so they won't go through the membrane.
What is plasma?
Plasma is the liquid between your blood cells. Yeah, they're too big to go through. Plasma proteins, I'm sorry.
And what else?
Red blood cells, white blood cells, they're too big to pass through, so they won't work for those. Okay, they do lose blood, and we'll talk about hemodialysis with that, but that's different. So they won't pass through the membrane. But smaller molecular weight substances can pass through. So they make sure they use quality water and those sort of things. Okay. Osmosis. Osmosis is the movement of water from an area of lesser concentration to an area of greater concentration of solutes. So sometimes they'll add like glucose to the dialysate, and that creates an osmotic gradient across the membrane. So it pulls the fluid from the blood. Okay? Ultrafiltration is the movement of solutes and water through a semipermeable membrane by hydrostatic pressure or pressure gradient. So there is an osmotic gradient or pressure gradient across the membrane, which leads the water and the fluid to be removed. So it's more of a pressure gradient. And I would focus on these definitions. They're right in your book, okay? Everybody good with these? You need another second? I'm sure you've had these before, right? In A&P, way back when. You remember? All right. So that's just kind of a picture I thought would be helpful for you. Osmosis, ultrafiltration. Like I said, we talked about the criteria for dialysis. Generally, their GFR is less than 15, like we said. But sometimes there's patients that have critical needs. So in an emergency, what would be an example of an emergency for dialysis? Can you guys tell me? Good. So hyperkalemia would be like an emergency, right? Why is that an emergency? Good, because they can have lethal dysrhythmias, right? So if a patient's potassium is like 7.0, we need to get them dialyzed emergently, right? So this can be a process, this GFR, getting lower and lower for a patient. In the meantime, they may plan for it ahead of time because they feel pretty sure the patient's going to drop and need dialysis. Again, it's up to the nephrologist, but other conditions like volume overload can be an emergency also. So if you're having a patient who is clearly overloaded with volume, they have JVD, they're short of breath, they have crackles in their lungs, they're struggling for air, you know that these people need emergent dialysis, right? So we have to look at that also. So other conditions, uremia, encephalopathy, neuropathy, like I said, uncontrolled hyperkalemia. Pericarditis is one also. So just, focus on these reasons, okay? And like, again, hypertension we talked about. All right. And the longer these people go without dialysis, the worse they're going to get, and eventually they're going to wind up crashing on you if they don't get treated. And you do have to be careful with dialysis patients. It really is a very fine balance with fluid. You don't want to give IV fluids to these patients, right? Unless you really have to. Because there's such dramatic shifts and changes in the patient's fluid status. As much as 200 mLs can throw them into overload. So you need to be very, very careful with their fluids. Sorry, my throat's getting dry. So we're going to talk about peritoneal dialysis. So here's kind of just a picture of it. Okay. So when we talk about peritoneal dialysis, it's becoming more popular just because of the ease of use for some patients. It's more convenient. They can do it at home. And it's just a little bit more controlling, like the patient has more control over providing the dialysis for themselves, a little more independence, put it that way, than hemodialysis. Hemodialysis is kind of like someone's doing it for you, versus with peritoneal dialysis, that person can be trained to do it for themselves. So there's differences, and we're going to talk about those. So basically, with peritoneal dialysis, the peritoneal membrane is what serves as a semi-permeable membrane. Okay, so your own body functions as the membrane. It works with diffusion, the movements of solutes from an area of greater concentration to an area of lesser concentration, lowering the amount of urea, creatinine, and uric acid and electrolytes in the blood. Again, we already talked about this, but the RBCs, the WBCs, and plasma proteins are too big to diffuse through the membrane. Okay? Everybody got that? Okay. We're going to talk about catheter placement. I think about 12% of patients are on peritoneal. So, not that, it's just a nice to know. Okay. We're going to talk about the different types. There's different types of peritoneal dialysis. Okay. Anybody need more time?
Just a dumb question. So, we're not doing anything for RBCs and WBCs. We're just staying inside while we're cleaning everything up.
Exactly.
Okay.
Yeah. You don't want them to come through the membrane. Yeah. Otherwise, you'd be very anemic and low protein. Yeah. And sometimes with peritoneal, that membrane, especially if you've had, we're going to talk about it, but if you've had repeated infections, that membrane gets more and more permeable, and that's more dangerous because then you will lose too much protein. But we're going to talk about that later with the complications. So good question. Okay, you guys ready? Yeah? Okay to go? Okay. So again, this is just a picture, but the client's own peritoneum serves as a semi-permeable membrane. Solutes move by diffusion and water moves by osmosis. Okay. And here's another picture of peritoneal dialysis. Your drain goes through the membrane and then out to a drainage bag. Okay. We're going to talk about how it works, but this is just a picture of what it looks like. And we're going to talk about the peritoneal catheter. This is kind of what it looks like. Okay. So the catheter, or peritoneal access, is obtained by inserting a catheter through the anterior abdominal wall. It is placed surgically. It's about 24 inches long and has sometimes one, sometimes two Dacron cuffs, which hold the catheter in place. They are also antimicrobial, so they prevent infections also. And they prevent migration of microorganisms. So once the catheter is in place, fibrous tissue will kind of grow around it and secure and keep it secured in place. So they use it pretty quickly, but they usually wait a little while before they use it. Not maybe a few days or a week. It's up to the surgeon. Okay. But fibrous tissue kind of grows around the cuff and then it holds the catheter in place. So the tip of the catheter rests in the peritoneal cavity. There's perforations in the catheter, so this allows the fluid to go through. Okay, so in order for preparation, what we do is we empty our bladder and bowel. These are just nice to knows. You, of course, get consent because it's a surgical procedure. And with any dialysis, what you always want for any treatment, before you start a dialysis treatment, what you know you should always have to get a weight. Good, weight, very good. That's how the nephrologists know how much fluid to take off or how much to exchange, okay? So, once the catheter is pretty secure and in place, then the patient can shower. Usually no bath though. Okay? And what are we going to teach our patient? Signs and symptoms of infection. Good. And that's really the big risk with these catheters is infection or peritonitis. So we really want to educate our patients on the signs and symptoms of infection. So what are we looking for? Right, around the site area, some redness, drainage, right? Temperature, right? If a patient has a fever, you might see an increased white count, right? All those signs of infection. And with peritonitis, we're going to talk about that too, but in particularly for peritonitis, you'll see cloudy effluent, okay? But we're going to talk about that. But for basic catheter care, you want to teach them the basics. Most of nursing, honestly, for helping these patients manage their own illness is to really help educate them to manage their own illness. And so education for nursing is a huge part of discharging these patients home with this types of equipment. Okay. All right, so we have our dialysate, which can come in different concentrations. This is just nice to know. It usually has glucose in it, and a similar concentration to plasma. So those are nice to know. It's usually warm to body temperature, and it depends on, the glucose is usually the osmotic gradient used. This is just a sample of the glucose bag. It's added to the dialysate, creating osmotic gradient across the membrane. So this process aids in removing the fluid from the blood. Ultrafiltration results when there is an osmotic gradient across the membrane. And I would focus on that. In peritoneal dialysis, excess fluid is removed by increasing the osmolarity of the dialysate by the addition of glucose. It's right on the slide, guys. Okay. There's different phases. You guys need to go back, or you got that? You okay? Yeah. All right, so there's different phases. There's 3 different phases of peritoneal dialysis exchange. Okay, the first one is called the fill inflow cycle or fill cycle. So this is the provider will order a set amount of liquid for this phase. Usually it's about 2 liters. And they usually do it pretty quickly, over 10 minutes or so. Okay. The second one is the dwell phase. And I would focus on these. They're right in your book. Okay. Diffusion and osmosis occur in this phase between the patient's blood and the peritoneal cavity. Duration can be it varies a lot depending on what type of dialysis, but between 30 minutes to 8 hours. And then there's the drain phase, which is the last phase. And that can take between 15 to 30 minutes. And sometimes if they have trouble with the drain phase and all the fluid coming back out, sometimes they'll massage the abdomen or change position. And it varies with the size of the person. You know, if there's a larger person, they may require more time. And smaller people do smaller exchanges. So the only bad thing with the dextrose in the solution is it's pretty safe, but sometimes it can lead to high peritoneal glucose absorption, which leads to hypertriglyceridemia and also hyperglycemia. So they can get high blood sugars if it's not done carefully and if it's over a long period of time. Okay, here's a picture of the little lady getting it at home. Okay, just want to see something real quick, sorry. Different types. Okay, so advantages of peritoneal dialysis. It can be portable, it can be done at home. You don't need a vascular access site. It's a lot less cardiovascular stress. Right, all this makes sense, right? A pretty short training program for folks. They have a lot more independence, like I was saying. They can travel, they can do it on their own. So it's kind of nice. They can still live their lives. There's fewer dietary restrictions. Greater mobility. Disadvantages. Lots of disadvantages as well. There's nightly cycles on the machine. You're always attached to a machine at night. There's of course the risk of infection, like we talked about. Hyperglycemia, like we talked about. Potential weight gain, especially in your gut, right? Protein loss. You do lose protein. And you have a permanent external catheter. I would focus on these. There's a chart in your textbook also. So there's actually a higher mortality rate after 2 years than hemodialysis on peritoneal dialysis. So not everybody selects peritoneal dialysis, and I would guess that would be the reason why.
Is it because of infection?
hard to say that, or just usually it's the case, infection, but yeah, but it doesn't have as good of an outcome. Long term, how much can your peritoneum function with, and then they usually change over to dialysis anyway. So, but yeah, I think that membrane just gets too permeable. Okay. And there's some contraindications for some folks that can't get that, so they have to get hemodialysis or transplant. So history of if they've had multiple abdominal surgeries, if they've had severe pancreatitis, diverticulitis, you can see any kind of real severe bowel problems, this isn't going to work if they don't have a good healthy membrane, right? Hernias, abdominal or inguinal hernias, if they're excessively obese, if they have bad chronic back problems, because it can cause some back problems, right? And also obstructive pulmonary disease, COPD. It's also going to press on your diaphragm. We're going to talk about that. So if they're already having trouble breathing, then probably would be good candidates for peritoneal dialysis. You guys good? Okay. So there's different types, like we talked about, and I would focus on these, and they're in your textbook. Okay. So the CAPD is performed every few hours during the day. They're manual exchanges, usually 4 per day, and they can be 4 to 10 hours of dwell time. So you can see this probably wouldn't be the one I would choose anyway if I wanted any kind of a life, right? So, but the bag of the fluid and the line can be disconnected after the fluid's instilled, so then you can be separated from it for a little while. So after the dwell is completed, then the line is reconnected for the drainage of the effluent. And then they hang a new 2-liter bag and they start over. The big important thing with peritoneal dialysis, and I would focus on this, is maintaining aseptic technique. Right? Because otherwise what happens? Peritonitis, right? So critical with these lines and disconnecting and reconnecting, aseptic technique is critical. And I would focus on that. So automated peritoneal dialysis is a little bit, I think is a little better for people, in my opinion, but and it's performed every few hours during the day, but it's it's an automated, it's used with an automated device like that picture I showed you with the lady sleeping. So it allows you to do it while they're sleeping for the automated peritoneal dialysis. So they use a cycler machine, it's called, and they can do it while they sleep. So an automated device known as a cycler is used to deliver the dialysate. It's pretty small too. So the cycler times fill, dwell, and drain phases. So it's kind of automated. There's alarms built in the machine, just in case. But it's all automated, all the different cycles and phases. So the patient can just disconnect themselves in the morning and they leave the fluid in the abdomen during the day. So sometimes they need to add daytime exchanges if they need more too. So, but it is in general nicer to use because you can use it during the while you sleep and still have your daytime life without being trapped to a machine, right? So, but there's about 4 to 8 exchanges a day, and 1 to 2 hours per exchange. So, but you can literally set it and go to sleep. Okay?
I have a question.
Mm-hmm.
So the leaving of the fluid throughout the day doesn't cause a problem?
Leaving the fluid throughout the day?
Yeah, because it says that throughout the day some of the fluid is left in there.
Yeah,
So that doesn't cause a problem?
it can. It depends. Not usually. I think patients kind of get used to it, but then they just set it to drain. But sometimes people get too much fluid in there, and it is uncomfortable for them. It's like carrying around a baby sometimes, you know. Yeah, and that can cause problems, especially back problems and other issues. So, and we're going to talk about the complications.
The APD then doesn't necessarily empty out completely.
Right, they do leave some in there. They don't leave the whole thing in there, but they leave like a liter or so in there until the next cycle. Yeah. But yeah, it can cause complications. And we're going to talk about those, especially like back pain, low back pain is a big one. Okay, speaking of complications, that's my next slide. We can have exit site infections, okay? In general, it's unlikely that like germs from your abdomen, like your GI tract, are going to cause an infection. That's pretty rare. And generally, it's an exit site infection from the catheter for not using a septic technique. Those are where the infections can occur. It's usually Staph aureus or Staph epidermis, those bacteria that are right on your fingers. Normal flora, you can even cause it, especially if your patient gets run down. We talked about signs and symptoms: redness, tenderness, drainage. They're usually generally treated with antibiotics. And if they're not treated immediately, it can progress to peritonitis. So you really want to be careful and keep a good eye on the exit site, which your insertion site is, which I showed you the picture where the catheter comes out of the skin. Right? Peritonitis is another complication. I would know these guys, okay? And this results from contact contamination, or like I said, exit site or tunneled infections when it travels into the peritoneum. And this can occur from improper technique when connections for exchanges are contaminated. Again, Staph aureus, Staph epidermis, same thing. And rarely is it intestinal bacteria crossing into the peritoneal cavity. It's not usually due to that. Manifestations of peritonitis, what do you think we're going to see?
Sore stomach.
Good. Pain, abdominal pain, rebound tenderness, cloudy peritoneal effluent with WBCs. So if we did a gram stain, we may see it, right? Greater, if they're like 50% neutrophils or gram stain cultures from the effluent grow, then we know we've got an infection, right? So we'll probably culture the fluid. We may have diarrhea, vomiting, abdominal distension, hyperactive bowel sounds. I would focus on those two. Patient may or may not have a fever. Pardon? Clear is normal, yeah. But if you have a cloudy effluent, that is not normal. That needs to be reported to the provider. Okay. So we can confirm we have peritonitis with a positive culture, right? And we would probably get a white count with a differential. We can give antibiotics to treat it, either orally, intravenously, or intraperitoneally. With repeated infections from peritonitis, this can be dangerous, right? Because eventually it's not going to work anymore. It's going to get like scar tissue, and then your peritoneum won't function anymore. And then you'll be having to take the catheter out and have to do hemodialysis. Another complication is hernias. People get these, lifting too much, right? Pulling the wrong way. So nurses need to take care of their backs, right? We get hernias. With increased abdominal pressures because of the dialysate, with peritoneal dialysis, this can cause hernias. Weakening of the muscle. Hernias can also develop with women who have had many babies, multi-para women, right? And older men. To treat this, we can do surgical repair. And once they're repaired, usually they can resume peritoneal dialysis, but they just do less volume. Another complication is low back problems. Obviously, we talked about that. Increasing abdominal pressures can cause or aggravate low back pain. If you already have low back pain, it will make it worse. Lumbar sacral curvature is increased by the infusion of the dialysate. To treat this, we can do binders to help support the abdominal girth. We can also do exercises, right, to help strengthen your low back muscles. Cardiovascular exercises, running, that kind of exercise will help those low back muscles. For anybody who does have low back problems. I know I do. Okay. Another complication is bleeding. So normal effluent should be clear, right? If there's blood in it, that should be reported to the provider. It's not normal. But sometimes it can be present if a woman is menstruating. So that's like the only time it can be normal. But otherwise it shouldn't be there. Sometimes people are on blood thinners and that can happen. So that's something that we need to address. Okay. And sometimes after the initial puncture, when you initially get the catheter put in, there may be a small amount of blood, but it should go away after that. Right? So it could be pink tinged effluent, but then after that it should be cleared up. And we have pulmonary complications. What do you think those are? Right, think of all that pressure on the lungs, and the lungs don't really have room to open up and exchange the air. So what is that called? Atelectasis. Good. So how can we fix this? Good. Incentive spirometer, yeah. But this is happening because the diaphragm is being displaced or pushed up. You can picture a patient with all this pressure on their diaphragm. So what would you do? Good. Set them up, right? Very good. Okay. So we can reposition them. We can teach them deep breathing exercises, like we said, or you guys said, with incentive spirometry, or just doing those in through the nose, out through the mouth. Kind of calm them down, relax them a little bit, and that will help our pulmonary complications. They can get pneumonia, but if we do all these preventative educational things with our patient and make sure they know enough to watch out for these things, they are very preventable. Another complication is protein loss, right? So, and we know our peritoneal membrane is permeable, which allows some things and proteins to go through, but we don't want too much to go through, but we will lose some protein, okay, during the process. So the peritoneal membrane is permeable to plasma proteins, amino acids, and polypeptides. And we can lose about 10 to 20 grams a day. If we have peritonitis, this can increase to almost 40 grams a day. So that can be, as the more permeable the membrane becomes, the more protein we can lose. Okay, so and we can do lab levels to see where we're at with the protein levels. So what would you teach your patient to do with this?
High protein intake.
Good, increase the protein they're eating, right? That will help. Okay. Because they can become malnourished. Yes.
So in the comparison table, it says one of the advantages to PED is patients with diabetes. If there's all these complications and risk of infections and stuff, why would it be most favorable for a patient with diabetes?
Why would it be mostly preferable?
Yeah.
Well, it doesn't cause diabetes, but because of the glucose in the dialysate, they're going to watch their glucoses. You're just going to teach them to watch their glucoses, their levels,
But
and
it
monitor.
says that it's preferable for patients with diabetes. But why?
Peritoneal dialysis.
Yeah.
If they have to choose between peritoneal dialysis and hemodialysis, I would say that's a good question. You know, we certainly do get plenty of patients with hemodialysis that are diabetic. You know, I would just say it's probably more controllable with their glucose levels. You know, but
Or they already have vascular problems, so you have to do a renal and vein, and they lose these pretty quickly. So you
Yeah.
have impaired circulation because of diabetes.
yeah, I mean, there's other complications of diabetes that can make it more risky to get hemodialysis, like Taylor said. But honestly, you just have to take each individual case. I mean, if they're severe diabetic, neither one may be a really good option, but they have to do something. So, hard to say. But I guess it's a lesser evil of the two. Does that make sense? But it's a good question.
I have a patient who said he kept having to get new sites because of it.
Right.
Because he's
Yeah.
diabetic, so-
And eventually their access, they lose their vascular status just deteriorates. So initially it's safer to probably start with a peritoneal and then do as much as they can do with that, and then go to hemodialysis as an ultimate. Yeah, but diabetes, no matter which way you look at it, neither one of those are great, but they're forced to do something. So, okay. Okay. So again, like we talked about, unresolved peritonitis can lead to repeated infections, especially if our sugars are out of control and we're more prone to infections. Then we will lose this option to have peritoneal dialysis because we would have to take the catheter out after repeated infections. And malnutrition be due to protein loss. So if we lose too much protein and we wind up getting malnourished, that's maybe a criteria for them to stop it. Okay. So we talked about the solutions again. So this slide just repeats what we just kind of discussed. Yes? They just go through the membrane into the drain, so you lose that protein. That's plasma proteins. That's, with hemodialysis. Yeah, that was dialysis in general. But peritoneal dialysis, you do lose some protein through the membrane. As that membrane gets more permeable, you lose more protein. So, but generally, that was general dialysis. So, hemodialysis, they wouldn't pass through at all. Does that make sense? Okay. I mean, ideally, you don't want a whole lot of protein passing through the membranes, but you get more with more proteins passing through with peritoneal dialysis and none passing with hemo. So, yeah. So you can eat more protein with peritoneal dialysis, for sure. So again, we're going to use aseptic technique. Sometimes we can get a catheter blockage too because of a full colon, so it doesn't always function. So then you would just give a laxative. If they have too much pain, we can slow down the flow rate, the inflow. That's another solution. Of course, if you find they're bleeding, we're going to monitor it, check our labs, hemoglobin, blood pressure, heart rate. Hernias, we said we can do surgical repair. For lungs, we can deep breathe, keep our head of the bed up. And for back pain, binders, exercise, we said, right? And for hyperglycemia, if we have, what helps is consistent dwell times and monitoring our blood sugars. And hopefully we don't have too much permeability with a protein, because there's not a whole lot we can do except for increase our diet. And again, we talked about signs of infection or peritonitis too, with cloudy effluent. Our WBCs are elevated greater than 100 cells per ml, and half of them are neutrophils. Again, positive blood culture by Gram stain would confirm diagnosis of peritonitis. No, sorry. Full colon can happen and can sometimes occlude the catheter and make it not function. Right. Full colon is just, sometimes that can happen if their colon is too full, which means they have too much stool in their colon, so you would give them a laxative. So if a patient's really full, you know, that can sometimes, I guess, occlude the catheter. Want me to go back a slide? Yeah, just sometimes a catheter can block if it's a full colon. That's all. Okay. What time is it? Okay, I'm just gonna see what my next slides are. Yeah. I think we'll stop here and take a break, and then we'll talk about hemodialysis. Y'all feel like you want 10 minutes? Okay.